I just want to talk about the Gravers Health Services journey with COPD. And so we started with some quality improvements in 2012. It was actually a project that I was not part of, but it dealt with readmission avoidance. And then we went to the second stage where we worked with IHI and CFHI, and we were working on AAA improvements. And then our current project is Inspired. So we're going to give you a little background of how we got to Inspired and some of the changes we've made along the way that you might be able to incorporate. So we're supposed to have a disclosure that we have a conflict with CFHI. I don't think so. They gave us a little bit of money and they're very helpful. But anyway, we need to make that declaration so there's and potential bias. Yeah, I think we're going to give you a balanced view because there's good and bad. And anyway, the COPD emission. So the COPD readmission, you decrease the readmissions through letting the Owen Sound Family Health Team know that a patient with COPD is being discharged. And we have an automatic firing when that happens and let them know that your patient has just got out of hospital. And they committed at that time that they would see the patient within 7 days of discharge. And we committed that we would have the discharge note to the Owen Sound Family Health Team within 48 hours. And we have continued to monitor that. It is important when you're doing these projects that you continue to go back and see if things are working. We found some things along the way that we thought were working, but we had to go back and review that, and the discharge summary was one piece, and we continue to go back and refocus, and that's one important thing to do. We're using COPD order sets and pathways. There's a self-management package. We'll talk to that later on, but initially, all the staff thought they were putting a great education package together. Subsequent to our work later on, we found out that patients didn't have the same opinion. And also, the CCAC, another one of our partners, had committed that their nurse practitioner was going out to see these patients after they got discharged. And there was a follow-up phone call, and we're continuing to look at a lot of different data sources to better understand our COPD. So, the second phase, AAA, we started a partnership with Canadian Foundation of Healthcare Improvement, who partnered with the Institute of Healthcare Improvement in the States and to introduce AAA within Canada. And so it's a triad that you're trying to improve three things at the same time: population health, improving patient experience, and reducing cost, and it's all done at the same time. So, I don't know if everybody can see that, but it says the road to understanding the patient's journey, and it says like step 2. I think you should be more explicit here in step 2, right? Then a miracle occurs. And sometimes we always hope for that, but it doesn't happen. So it is important to really try and understand what's happening with your patient. So this is actually a map, probably 10th version out of what we started with, which was pages and pages long. But we did actually have several sectors from the Owen Sound Family Health Team, from CCAC and ourselves, trying to see how the patient entered the system, what was working, what we needed to improve on, and that kind of set the stage of what we need to do. I know that you can't see it, but it's just to show that you really do need to map out each step, and it takes a while to do that, but it is important to do it. So, our COPD REACH project, so it's realizing excellence in advancing chronic health. So we decided to look at some projects in relation to those three parameters. Population health, we were looking at things like the COPD admission rate, mortality rates. We actually introduced a no smoking policy on our grounds last year, so we were also working on smoking cessation with our patients, and that aligned very well. And the improved patient experience, And we did a lot of work as far as learning from our patients. You probably can't see too much on the right-hand side, but basically it was a lot of work that we did when we talked to the patients themselves, and we actually analyzed the outcome of that. And we also looked at costs, which we looked at ER visits, length of stay, admission rates. So, Val is our expert in measurement, and she never takes anything at face value. So she looked at one data source, and then she looked at another data source, and our priority was to pull everything together, so we identified the top 10 patients that used our system. So that took a while, but when we finally understood that, then we actually decided that we're going to do a robust chart review and trying to understand what was happening with those patients. That's not always hard. I don't know how many people have actually tried to do chart reviews to really find out what you want to find out, but that takes a while. And we actually had a late career nurse that was doing that for us, and we learned a lot through that. And we did two things retrospectively. One's the NICE tool, which is a validated tool that you use to see if your patient should have got admitted. And the LACE tool is a tool that you use when a patient's in the hospital, and that's to see if they're at risk for coming back in. And we got about a 66% rate of seeing if they match. So it wasn't quite clear, and we think it's because we actually couldn't get all the information from the chart that we really wanted to. And then we decided that we're going to be very adventurous, and we were going to do home visits. The first project had actually tried to do patient interviews in the hospital, and you do not get the right answers when patients are in your hospital. They give you the answers that they think that you want to know. They don't tell you the truth, and you don't find out the reality of what's going on in their homes unless you do that. So, in a previous lifetime, Val used to actually be a mental health nurse, and she was very adept at doing patient interviews. And actually, the late career nurse from the critical care area also had a mental health background. And that really helped them going into situations where the patient perhaps viewed you with some suspicion, what do you really want? But we gained a lot of valuable information, really learning a lot of the social determinants of health that were impacting these patients. And until you really learn that, you can't determine what your patients really need, and you have to ask them what they need. So hospital-based clinics are great, but until you get out in the home, you will realize the true challenges of those patients, what they're living like, and why they don't come to their appointments because they don't have any money, or their relatives won't take them, or they can't afford to fill their prescriptions, or maybe their relatives that they're living with really aren't helping them. We live, in Sound, but a lot of our patients live in rural areas where we don't have any public transportation. So sometimes when you view patients as being non-compliant, they don't have any choice. But doing those, even if you have a chance to just do a few home interviews, it's really valuable, and it certainly has set the tone for us going on to our next project, because we realized that we were failing our patients. So when we got the opportunity through CFHI to continue our work with them, we jumped on it and applied to be part of the Inspired project. And I see some people from London are here that are also in the project. But I have to have this because I never remember what the Inspired part is. But it's implementing a novel and supportive program of individualized care for patients and families living with respiratory disease. And it is a different way of looking at it, where we start a relationship when the patient is in the hospital, but we continue that relationship with the patient in the home. We use an RRT, and she is also a CRE, that's Shaundra. And in spiritual care is a key component. Angela is our lead lead on that, and they play the role of emotional support, and they are considered a key member of the team and not just an ad hoc that they often are visualized. But these people are really, really valuable because the patient focus of Inspired is actually patients that are entering towards the end stage of their disease process. And I don't know how many people out there have dealt with patients that have had a chronic disease for 40 years, but they still haven't dealt with what they want as their end of life nears, and they don't have a care plan, and their family doesn't know what their wishes are. So part of the spiritual care role is to talk to them and create a relationship with them and actually develop an advanced care directive. The advanced care directive actually in Inspired is very unique because it asks questions that perhaps we don't ask. Like, what is more valuable to you, being lucid or being pain-free? Usually in hospitals we ask them if they want to be attached to a ventilator. So it's a different approach, takes a long time, and that's another reason why while looking at various sources of support for these people, sometimes you have to look in a non-traditional fashion, and people that have the time to dedicate to the patients that really need this valuable experience, and it does take a lot of time. Angela can talk about that. So we started our Inspired journey by being selected as one of 19 teams that were selected across Canada to work with CFHI. We're the only rural site team that has been selected, and so we're in a unique position on that. In September and October, we spent establishing our team. We had already started with relationships with our local CCAC, our Owen Sound Family Health Team, which has a roster of 30,000 patients, and one RT. And we also have established relationship with our EMS. We're also currently working on emergency paramedics in the community project. And that's also important that you're working with all your partners and understanding what all their projects are. So we actually have followed the Inspired model that was set up by Graham Rocker, and he has had a profound reduction in ER visits and admissions to the point of 60% reduction. And that's why we were keen to look at this model, because other models have not had that success. And it is looking at the patient on an individual basis and seeing what they need and doing it outside the hospital. October and November, we started doing the evaluations, and Shaundra goes in, when we have patients, she looks at the patients in the hospital, and she actually looks at who has COPD and see if they qualify. And we are looking currently at patients with a MRC scale of 4 and 5. Those are patients that are very short of breath with fitting movement, and has started to actually look at patients with level 3. And we have to get their consent to participate. And once we do that, then we tell them that we're going to be following them in the community. We also have CCAC being notified as well. We're working alongside with them, and they're having a rapid response nurse as part of this project. And the Owen Sound Family Health Team is also being notified when we put people in to the program. So far, because of the parameters of the program, they also have to live within 25 kilometers of the hospital, and they can't be in long-term care facilities. So within that spectrum, we have reviewed 12. We currently have 7, and 3 have already passed away. 1 declined, and 1 was in placement. And it's interesting because I asked Val the other day, could you actually tell us what happened to the patients after they got admitted into the Inspired program? So the 3 patients that passed away did not pass away in the hospital. I think 2 were in hospice. The 1 patient that declined to go into our program passed away in the hospital, which is a little early to tell if it's a trend, but we found that very interesting. So what's the new model look like? So the patient is admitted to hospital, and then Shaundra goes in and makes that initial contact. And then we look at sending the patient home, and that we are going to be following up with them. We hope eventually that we're going to see a decreased length of stay, but because we're early on in our journey, we haven't been able to measure that yet well. And that we are also linking with all our services. I think we're a little bit have an advantage in a small community because we know who everybody is. So in large communities, when you're trying to find out who is who, it takes you time to figure out who you need to talk to. We already know who everybody is, so they can't hide from us either, so that's an advantage. And then there's a series of home visits, and this is not emergency care, right? We have a care plan that is signed off by our respirologist, Dr. Mark Newton, and it deals with kind of what you traditionally know, the red, yellow, and green zones, but also deals with a few unique things, and including using a handheld fan to help the patient with breathlessness. But it also includes, for those patients who require it, the use of opioid therapy to help them with their breathlessness. We don't have actually everybody currently on the opioid therapy, but our palliative care physician is also involved in our program, and she's supportive of putting people into this program and has helped us. So there is a typo. Typos always bother me, but this is my slide, so it says what? It should say what matters. So you will see on your left what matters to the caregivers, and on the right what matters to the patients. So it is interesting. For the patients, it is that they don't want to be a burden physically or emotionally to their family. The second is that there is an adequate care plan for them. And the last one is that they have trust and confidence in their physicians. The caregiver, on the other hand, doesn't feel the same way. They want to know which doctor to contact. They want their family member to have relief with physical symptoms, and the last that's important to them is the care plan. So it is interesting, and that's a study that Dr. Rocker was part of, and you can see that they dealt with 37 families with that. But I thought that was an interesting slide to bring up. So at this point in time, I'd like to introduce Angela Schmidt, who is part of our spiritual care, and she's going to tell you about one of our patients' stories.
So I'd like to tell you about Carol. Carol is 77 years old, and when I first met her, she was in hospital. One part of our program is that if we're able, we try to connect with the patient while they still are in hospital before we go out to do a home visit. And part of that rationale was just to begin that building of relationship. So you'll notice what's missing on the slide that you'll often get in healthcare, right, is all the diagnostic information. Because our role as spiritual care provider is to get to know the person and who they are, and how they've lived their life, and how they see themselves. And not to get lost in their symptoms and in the medical needs that surrounds them. So Carol was a 77-year-old woman, and when I first met her, she was a frail woman in the hospital bed, shock of white hair, and one of those sparkly smiles that the whole room lights up when you come in and meet her. The role of the spiritual care provider on the team is not only to connect with the patient and to support them emotionally, spiritually, but is to help to give the patient an opportunity to talk about what is it like to live with this illness. So in this case, what's it like to live with COPD? Because we often talk about what is it like to manage the symptoms, but not what the experience of the illness is. And we do that by targeting all kinds of areas, and it can be about their personhood, their hopes, it may be their faith, or the places in their lives that give them strength. We explore their support system, and Jane has alluded to that in terms of we explore what their very basic needs are, because there's a lot of hidden needs that patients won't talk to you about until you ask specifically. And then last, of course, we talk about advanced care planning. But we move slowly in all those conversations. So as I got to know Carol, one of the first places we began was I asked her, Carol, how has your life changed since the diagnosis of COPD? And one of the first things she said, everything in my life has changed. She told me about her work experience. She had worked at a golf and country club. She had had a very active social life. Her husband had died 7 years earlier, and she, even though she had grieved, she had sort of looked forward to this next portion of her life. And 3 years earlier to now, she had a diagnosis of COPD. And what began to happen is her life began to shrink. And so she said in the beginning I couldn't work anymore, and that was really hard, but people would still call me or they would drop by. And she said as I became more and more ill, people stopped coming by, and eventually I couldn't live in my own home and living now with my daughter. But her world continued to get smaller until at that point in her life she had one friend who she would continue to have a phone conversation with. She lived with her daughter, and her daughter would go to work during the day, and she would be alone from about 8:30 in the morning until 6 at night. And so we talked about what that is like and how she manages the day, because not only did her social world get smaller, but her physical world got smaller and smaller to the point where she was in bed and had enough energy to get herself to the bathroom and back. So we would talk about very basic needs, whether or not she had the energy to get to the kitchen, to open the fridge, to get her lunch out. And what can happen with COPD is just that deep sense of shame, of wanting to be able to take care of oneself, of not being able to, and needing a place to put that sense of shame and deep vulnerability. So our conversations, that we go in and spend about an hour at a time, and it was first to get to know her and to explore the illness, but also giving her opportunities to articulate some of those areas of pain and discomfort, but also the areas that give her strength and hope. So we talked about the places in her life that have brought her great joy. And I asked her, what is it like for you to, she could no longer read, she could no longer knit, and I said, what is the experience like for you? And she said, you know, I kind of live in my head. So we talked about how she does that. One of the things that I asked her, because I am the spiritual care provider, I said, Carol, I don't want to make you uncomfortable, but I'm wondering if you ever have a conversation in your head with God. And she laughed and she said, you know, if I'm honest, I talk to God all day, every day, but I have never told another living soul about that. She's not somebody who you would ever say has been an active part of a church or faith group. She's not somebody who you would peg as overtly spiritual. But she had a deep life that was her own. And so then we talked about what her hopes are in regard to her future. Hope is what sustains us. And hope can be very small. I hope to be able to get up today to get water for myself. Hope doesn't have to be big. I hope to be able to see my grandkids on the weekend. Carol's hopes was I want to be with my family. That's the most important thing. She had adult siblings, and they would come in at lunch and bring in Tim Hortons hot soup for her, to make sure that even though they lived quite a distance, they had orchestrated a schedule so that they knew she got hot soup at lunch. Part of her hope also was for time. And so I said, Carol, tell me about what time means to you. Because in my head, I was hearing I want to be able to live a long time. And her idea was not in terms of I want to live a long time, of I want to live the best that I can in the time that I have. She knew her time was short. And the more we talked about it, I could tell it wasn't an issue of denial of her illness. But again, it sprung from that hope of, I'm not done yet, and yet my body is done. And so then I asked her whether or not she had any hopes of what would happen when she died. We talked about what kind of scene, what kind of deathbed scene that she would like, whether or not she wanted people present with her, whether or not she wanted music, whether or not she wanted a minister or somebody. So we became very specific in terms of what was important to her. And then I asked her whether or not she had any beliefs of afterlife. And she had a very clear belief system within herself, and so she talked about her desire to see her husband again and what that meant. And so it gave me an opportunity to ask her if she was afraid of dying. She smiled, and she had very little breath. And so when I talk about these conversations are punctuated with long pauses, with time to reflect. And so even though I'm telling you quickly, Carol and I spent a long time just being with one another to give her space to think, but to give her an opportunity to speak at a level that was comfortable for her. And so we talked about using the time out symbol or whatever would give her time and space. So her hope was to go to heaven, to be with him again. Building a relationship with the person with chronic illness becomes very important because it's not the sort of thing you can rush in 20 minutes and rush out and do. If you really want to get to know somebody, you have to know their story. You have to know what's important to them because we're guarded. We're all, in terms of what we're really going to share with individuals, and it takes a while to move down to those deeper levels. I met with Carol twice in the home and a number of times in the hospital. In the home, we began what Jane referred to as the advanced care planning document. So we started with what were the things in her life that gave her life meaning. We moved into the goals around her care. And again, the goals of what was important to her is not always what the healthcare team might have first identified. And then we moved into the very specifics of interventions and life-sustaining interventions. And then lastly, what she wanted right at the end of her life. And then I asked her if it was all right if we did this with her family, so that her family would really understand what was important to her. Because you don't know how long somebody's going to live with COPD. They can live for quite a long time, or illness can take them quite quickly. And so she said that would be helpful. Many of these conversations are not only punctuated by pauses, but also by tears. And so it was really important to Carol that her family understood what was important to her. She didn't have the breath to articulate it all. And so it ended up that Carol went into hospital precipitously, and we weren't able to do the advanced care planning piece that we had set up with her family at home. And so I asked her family member if it was all right if we did it in the hospital. At that point, she had very little breath. Because we had already done this piece, as we began to move through the document together in terms of the places in life that gave her life meaning, I articulated to her family what she had been saying, and then Carol was able to nod, or she was able to get a few more words that could add to it. It was a deeply moving experience, though, for the family to hear Mom's words and to know what was most important, and also to reveal the spiritual side of Mom in a way that honored her. As we moved down through interventions, it really helped the family to understand why certain things were important to Mom, and that Mom was okay with dying. It helped the family to have a place to put that grief and to not feel like we're making the decision about whether or not Mom lives. This is that Mom is okay with the dying process. And so we moved through those pieces together. It's also essential, though, that we maintain that relationship. This relationship between the RT and the spiritual care providers, we found that it's really important that we be dialoguing, so that as Shaundra goes out and then lets us know her experience in the home, we know what we're coming into. But the people in the home also really appreciate the time. So the time to build the relationship, time to give the patient an opportunity to talk about their spiritual side, It's not the sort of thing that you can just quickly ask, do you have a faith or do you attend somewhere? It takes a while for people to trust you enough to share that side that is very private among ourselves. Giving people an opportunity and family members to say goodbye is also really important. And our learnings that we've taken out of this is to ask about the hidden needs. Asking whether or not people have money to buy food. Asking them whether or not they have money to get to pay for a taxi to get to the doctor's appointment. And so part of our role then has been connecting people into community resources. If we can work down the shame factor, then people are open to say, here's where my needs are. Our learnings have been about how important the conversations around dying are. The people want a chance to talk, and as I explored with Carol about dying, she said, everybody talks to me about the symptoms and managing the symptoms. Nobody talks to me about dying. And she appreciated the chance to lay out what was her perspective, and then she really was okay with it all. We've learned a lot about what it means to be a team and to network closely with one another, but most of all, I think we've learned that we need to keenly listen to the patient. We're good in healthcare at saying, the patient is at the center, but it takes a lot of effort to keep the patient at the center, and Inspire is one of those programs that really works hard to enable that.
So doing a program of any kind is not without its challenges. And one thing that is particularly difficult sometimes is sharing information across sectors. And we continue to work on problem solving with that, but one thing that we came up with was we actually are using SharePoint. And we have dealt with our privacy officer to allow us to use this Dropbox method so that our team, the On-Sound Family Health team, and the CCAC will share information through this. We have limited the number of people that have access to that, but it's been very valuable. I think everybody knows with QVPs, you need to know if the patient has spirometry. It's not the time to do the spirometry when they're in acute respiratory failure coming into hospital. Often being done now, and family health teams have that resource, and now we can get that very quickly. We're starting to work with CCAC. One of the challenges we've also found is the language that we speak is not always the same. So what a care plan in the hospital might not always be the care plan of what another sector calls a care plan. And so it's taken some meetings and conversations to come up with what that means and having a mutual understanding of what we require and what we want to see from each other. So one thing to know when Mr. Smith leaves the hospital and then Mr. Smith is back, is what's happened that caused Mr. Smith to come back. When we get to a point that we can know exactly what's happened with Mr. Smith, that he couldn't get to his follow-up appointment with the On-Sound Family Health team, that he decided that he didn't like to have a nurse coming into the home, he's a very private person. So those types of things, when you can figure that out easily without spending a lot of time spinning your wheels, is very helpful to have that and understand the story to try and mitigate that from happening again. So we have just started to have electronic charting on some of our floors in On-Sound, but that does not negate the challenges of finding the information I alluded to. What you need to know about the patient when you do chart reviews, it just doesn't pop right out at you. So it is very time consuming, and I think it will continue to be so. I think if you've ever dealt with any lawyer speaking about if you have to go to court and they have to pull an electronic chart to take to court, they will say that it's very difficult to find out the patient's story, and definitely it continues to be that way. And we continue to pull different sectors of data to find out the information from RIDS to DADS to our power chart information to tell the full story and keep going back to that and really trying to find that in the middle of winter in no sound is not easy. And we actually had to order them. But that is part of the small little thing that makes a difference with people that are short of breath, just putting that in their face and they get relief. So it seems like a really small thing, but it's really important to the patients, and they do see that there is a difference having that. So we've gone out and done that. So we are early in our stages for the inspired data, but we're looking at our COPD data on the whole, and then we're going to do kind of before, during, and after data collection for our inspired patients, just to see what the difference makes. But you do have to have a larger number than what we have yet. So we can tell you that this is mentally taxing for any team, and having talked to the London team, I think they concur. This is very challenging going into people's homes. Some of the stories are challenging. Some of the environments are challenging. And it is a really good idea if you're going to try something like this, that you have a way of bringing your team back, debriefing, having people to talk to, trying to, how do we deal with some of the more challenging patients, and that's really important. And a lot of us who have grown up in the hospital environment are not used to going out into people's homes and doing those very challenging interviews, and it is really, really important that you don't forget who your team is, and are very supportive of them for sure. It's also very important, when we were in Vancouver and all the teams across Canada were talking, and one of the very large facilities was saying, you know, we didn't know all the COPD programs that were going on within our own hospital. So it's really important that you know what work that the other people are doing, and that you can try and merge them when you can, or at least be respectful and understanding of what they do or they don't do. And I think I alluded to the EPIC program, and their population that they're seeing with the paramedics in the community is CHF, COPD, and diabetes. So we've had a bit of a challenge in making sure that we don't overlap, because they're actually in a clinical trial. But we have also had the fortunate relationship with them that there's other things that we are looking into, like remote monitoring for our patients, which is really cool. I just saw it last week, and you can download information. They get like power chart popping up for the paramedics. They have parameters where they get outliers. They can do even an electronic scale for CHF patients, and they get alerted if the patient's gaining more than 3 pounds. The stuff that's coming in the future is really, really neat. So we want you to consider that what Inspired is for COPD, but you can look at a structure for any chronic illness that would work. So the COPD structure would work for CHF, would work for people with renal failure. That structure is really important, and once you get that down, I think you can translate it to any chronic disease management. We've already talked about understanding your data, so don't just rely on one person saying this is your data, that's what it is for sure, and go with it. You really, really need to understand what you're looking at and making sure that your understanding is correct or not. The key point is what matters to the patient. It's not what matters to you, it's what matters to them. So one example, and it's not COPD, but it's one that I heard for CHF, and what mattered to the patient was that she could wear shoes instead of slippers. It was like going out in public and being able to wear a pair of shoes. So it's not a huge thing. Shaundra had a situation where she actually saw a patient in the hospital. And as an RT, she would have never thought about it, but the patient came into the hospital and she had a minced diet. And she said, this has made such a big difference in my life, because even having a meal made her so breathless, but having a minced diet made a huge change for her. So it's appreciating what is important to the patient, and that's what the focus has to be, and the patient's goals have to be part of the care plan. It can't be your care plan. The spiritual care part, as you can see, Angela's been able to give patients an incredible amount of time. These patients don't have to be religious patients. She's giving spiritual support, emotional support, and it's time that acute care people do not have time to do. Our advanced care plan usually just takes a few minutes when somebody comes into the hospital, and I know that nobody has spent hours with the patient. This is something unique, and I think it's something really, really serious that we need to think about. And so when patients are coming in, rolling through the emergency doors, that we're not wondering if they want to be put on a ventilator. One thing that we have done in Owen Sound is we use Cerner, and we use an alert. So alert code 1 comes up with anybody inspired, and their advanced care plan is coming up with that, so that the ER physician can bring that up quickly and understand what the patient wants. And that's been something that's been very valuable. And again, it's bridging. So this is what HealthLinks is all about, bridging all the sectors of healthcare to bring together to what is best for the patient. And keep in mind, it's what's best for the patient, not what's best for your service, and then you'll have success. Just, you wanted to see a little bit of our numbers, so this is actually just preliminary. So you can see that we made a difference in the length of stay. We've taken out the ALC days because we don't have a lot of control of that sometimes with trying to get people to nursing homes. And we've had over 100 less visits to our ER department. So it is making a change, and we're hoping that Inspire makes a whole lot of bigger change to these patients and their families. And we are hoping that we have